We'd like to welcome all of our viewers and listeners to another Road to Wellness webinar. I'm Kathy Olevsky, and I'm the host of the Road to Wellness educational webinar series for the Vasculitis Foundation. I'm a patient, just like many of you, living with vasculitis. I was diagnosed with ANCA-MPA in 2008. I was in treatment for 6 years, and I'm extremely grateful to have been in remission for 8 years and off treatment. So I hope to help the vasculitis bring awareness to the various vasculitis diseases. And today we're talking about aortitis in one of our series of disease-specific webinars. So I'd like to begin today by introducing our two guest speakers. We have Dr. Augusto Vaglio, who is an associate professor of nephrology in the University of Florence in Italy. He's part of the European Vasculitis Society and is interested in ANCA-associated vasculitis, IgG4-related disease, Erdheim-Chester disease, and lupus. Dr. Vaglio also spent a research period at Emory University under the supervision of Dr. Cornelia Weyand. We also have Teresa Searles. She's a 56-year-old patient living with aortitis, and she's from Seattle, Washington, and was recently diagnosed with Bartonella-Hensley neuroretinitis infection that may have been the catalyst for her diagnosis of aortitis after a PET scan. And when her health allows, Teresa enjoys hunting and fishing. So welcome, Dr. Vaglio and Teresa, and we're so happy to have you join us to educate us about aortitis today.
Thank you.
And I would love to just turn everything over to you, Dr. Vaglio, so you can show us a presentation and help us understand a little bit about this unique, or as Teresa says, unicorn disease.
Okay. Thanks very much, and it's a pleasure for me to be here in my apartment, here with you. It is a shame at the same time that we can't meet, but I understand this is the time where we need to, accept that many things are online, and I always complain about things done online, but I understand the value that these series of webinars or lectures might have for people who can't move too much. But I really hope that this is going to change, and I'm pretty boring in my talks because I always start with a complaint of doing it online. Except so. Besides this, I would like to thank because this is not a common opportunity for doctors to speak to patients. I don't want to look like the good doctor. I think we are privileged in doing our job. It's not a mission. It's just it's just a pleasure. And but sometimes we have some difficulties in talking to patients, and I think this is a good exercise for us because translating what we usually say in a sort of medical language into a lay person language is not so easy. So please, the best approach to me is if you ask questions and I try to be as clear as I can. I just prepared a few slides to introduce the topic of aortitis, and I will also try to differentiate this from what we call peri-aortitis, which is a closed disease, and I'm particularly interested in peri-aortitis, which has been a theme, a topic of research for me for the last 15 years. So I try to share my screen. Can you see my screen?
Yes.
Okay. So aortitis is generally a very sort of generic term which indicates inflammation of the aorta. We know that the aorta arises with the thoracic portion, which is the ascending, the aortic arch and the descending aorta, and then continues to the abdomen, where we find the abdominal aorta, which then bifurcates in the two common iliac arteries. And this is a very important vessel. This is the largest artery that we have. The biological systems are sort of built to protect this site. It's not like a joint, or it's not like a portion of the skin. This is essential for our life. This is essential for the blood to get to all the organs in our body. Therefore, our biology preserves this site as a very, very important site. And this is also why the inflammation of the aorta is a very rare condition. It's also because it's really, really life-threatening sometimes. One important thing to know about aortitis is that it is not, it usually is part of a systemic disease. That means that when you have aortitis, you might also have another inflammatory condition, which might involve the arteries, but it may also be totally different stuff. And generally, it's in the setting of autoimmune diseases, immune-mediated diseases, or infectious diseases. The aorta is comprises three different layers. The inner one is called the intima. Then we have the media, and then we have the outer part, which is the adventitia. And in the adventitia, we have some small vessels which give, which sort of, nourish the aortic wall. But these vessels, which are called vasa vasorum, which means the little vessels of the big vessels, they can become inflamed, and they can be the port of entry for inflammatory cells to attack the aortic wall. In general, when we say aortitis, we mean generally a generic inflammation of the aorta, but we need to be more precise, and we need to clarify whether the thoracic part of the abdominal part is inflamed, or the thoracoabdominal aorta. So we can have, as in many vasculitis, the vascular territory which is inflamed has some skip areas, so some areas where we don't have inflammation, we don't know why. This is the case of large vessel vasculitis, such as giant cell arteritis, such as Takayasu's arteritis. These are typical examples where the inflammation of the vessels is limited to segments of the temporal artery, is limited to segments of the aorta, is limited to segments of the carotid arteries, for instance. So we will not be surprised if in a condition like aortitis, we only have some portions of the aorta which are inflamed and others that are not. The most difficult thing in the diagnosis and management of aortitis is suspecting the disease, because the clinical manifestations and the symptoms of aortitis are often very unspecific. And we will go deeper into this point. We can classify aortitis from many using different criteria, thinking of the localization of the disease, thinking of the etiology, so that means the cause of the disease, or also when we look at the biopsies that are taken sometimes, of this tissue because the patients undergo surgery, and so we can analyze the surgical specimens. We can also classify them into different types of disease based on the histological appearance. This is more medical, I would say, as a classification. It's sort of difficult to understand for people who are not in the field. But you might be familiar with terms such as granulomatous inflammation, which reminds of diseases such as granulomatosis with polyangiitis, which is GPA, or Wegener's granulomatosis, which is an ANCA-associated vasculitis. And we can have inflammation of the aorta, and we can have aortitis during the course of GPA. Another granulomatous disease is giant cell arthritis. When we say giant cell, it's because we have some cells which have multiple nuclei. It looks like a very big cell with many different cells inside. And this is another example of a granulomatous aortitis, and this belongs to the spectrum of large vessel vasculitis. Again, another granulomatous condition is Takayasu. But Takayasu has a very different presentation, has a very different epidemiology. But this is again a cause of aortitis. Then we have another disease which is emerging, we can say, but it has already emerged during the last 10 to 15 years, and it's called IgG4 related disease. This is an immune-mediated disease. Again, it's not simply a vasculitis. It's a disease which can affect the pancreas, the retroperitoneum, the biliary tract, the salivary glands. So many different parts of the body, many different organs. And one of the main complications is aortitis. So you can see that there is a very wide spectrum of conditions which are complicated by aortitis. But the common denominator is that we can understand that aortitis is a manifestation of a complex disease. It is rarely a disease limited to the aorta. This is again a sort of classification. Well, why do we need classifications? Because when we understand that aortitis is secondary to giant cell arthritis, when we think that it can be secondary to GPA, that it can be secondary to Behçet's disease, the management changes significantly, and the therapeutic approaches that we use in the different conditions are very different. There can be distinct approaches. So it's I want to underline this point, because I think that I seldom or probably never saw a patient with a diagnosis of aortitis who did not have another disease manifestation which was not part of a complex systemic disease. So this is the message for the clinician, but this is a message also for the patient. When you receive a diagnosis of aortitis, you should wonder whether it is secondary to some immune-mediated disease or other causes. Historically, aortitis was also bacterial. Many diseases can be complicated by an involvement of the aorta, such as tuberculosis, syphilis, bacterial infections by Staphylococcus aureus or other types of bacteria, fungal infections. But you can understand that if we have the involvement of the aortic wall during the course of an infection, that means it's a very severe infection. It's not just, a simple urinary tract infection. This must be an infection that goes deep into the organs, that can have access to the aorta and inflame the aorta. And this is particularly relevant for patients that have immune deficiencies, whether it so that have that we usually say they are immune compromised. That means they might have HIV, they might have received immune suppressive treatments, they might be fragile for cancer or whatever. So when we have an infectious aortitis, that is usually a complication that occurs in a patient with a very severe infection, and a patient who has sometimes or often immune deficiencies, whether they are acquired or primary. That's another point. In some cases, this inflammation of the aorta can extend and be and become very, very thick. And this happens especially in the abdominal aorta. And here the disease changes, because the complications are not only related to the inflammation of the aorta, but also to the formation of a thick tissue that surrounds the aorta and can entrap neighboring structures such as the ureters or other vessels of the inferior vena cava, and that changes a lot the clinical picture. This is a distinct disease. We call it periaortitis. It's usually secondary to IgG4 related disease, but it can also be isolated. It can be secondary to cancer or histiocytosis. It's a very difficult to approach disease, but sometimes it's not easy to differentiate abdominal aortitis from abdominal periaortitis, because this is mainly based on the thickness of the periaortic tissue, of the periaortic inflammation. I just said that it's very difficult sometimes to suspect periaortitis or suspect aortitis. This diagnosis has become, I would say, more frequent during the last few years, also thanks to the advent of imaging techniques such as MRI, CT scan, angio-CT or MRI angiography, and especially PET scan, which has become whose use has become more widespread in the last few years. And this allows us to visualize the aorta and to detect with very good sensitivity if the aorta is inflamed. So the diagnosis has become a little bit more frequent, but still we don't have any key symptoms, because the disease can present in a very insidious way with systemic symptoms or fatigue or chest pain, abdominal pain, fever, low appetite. But its presentation can also be dramatic, because we can have rupture of the aorta and the patients may even die sometimes for this complication. Sometimes we might have some cardiac symptoms, such as palpitations, such as shortness of breath, and this is due to the involvement of the thoracic aorta and generally of the first part of the aorta, which the one that is attached to the heart, and this causes valvular insufficiency. Sometimes aortitis can be combined to the involvement of other vessels, the vessels that go to the head, so the carotid arteries, the vessels that go to the arms, such as the subclavian arteries or the axillary arteries, and therefore the complications are due to a low blood supply to these structures, and we might have dizziness. We can have a reduction in the strength of the upper limbs. We can have many different complications. So you can easily understand how the heterogeneous is the clinical presentation of the disease. And you need to be a very good doctor, very curious doctor, you need to think of a rare stuff when you see a patient with symptoms like these, which you hardly can combine. You have a very hard time in making a diagnosis of a patient with systemic non-specific symptoms. It's easier to make a diagnosis of a patient with chest pain and cough and fever. You say, okay, do a chest x-ray, you find pneumonia, and that's a very straightforward diagnosis. But when a patient has fatigue, he's got inflammatory markers, but nothing that, reminds you of an organ involvement, and everything is so silent, that's a very tough diagnosis. The complications of peri-aortitis are different. As I said before, this thick tissue which surrounds the abdominal aorta can compress structures such as the ureters, which are, when they become obstructed, they can lead to renal insufficiency, lumbar pain. Sometimes the tissue compresses the veins, so we can have edema of the lower limbs. But in some cases, we can also have aneurysmal dilatation of the aorta, such as it just similarly to aortitis. This is a common complication of these diseases because the wall of the aorta becomes inflamed, is less resistant, and tends to dilate. And the formation of an aneurysm is something we have to follow very closely. Because it can, lead to rupture of the aorta. This is a case of aortitis in a patient with a large vessel vasculitis. It can be visualized by different imaging techniques. The main techniques to get to the diagnosis of aortitis are MRI, CT, and PET scan. But once you have a diagnosis of aortitis, you need to look for the causes. And it is quite frequent nowadays that you first get a diagnosis of aortitis and then you go and study the patient and find that the real name of the disease is Takayasu arthritis, giant cell arthritis, lupus erythematosus, GPA, IgG4 related disease. So I would just like to leave you with this, which is a chest CT scan, a computed tomography, where you can see this is the aorta, this is the ascending aorta and the descending aorta. You can see it better in this scan. This was a man with palpitations. He was a non-smoker. He had a mild increase of inflammatory markers such as the C-reactive protein and the sedimentation rate. And he did a chest CT after doing a plain radiography of the chest, and they found this big aneurysm. This big aneurysm, which is, I would say, of large enough to be considered for surgery. And this patient was kind of a surprise for the vascular surgeons, because aneurysms in general are due to, or they occur in patients that have risk factors for atherosclerosis, such as smoking, obesity, diabetes, hypercholesterolemia. But this patient was slim. He was not that old. He was a non-smoker. His glycemia and his cholesterol were nice. And he had inflammation of the aorta, which led to the formation of an aneurysm. So whenever you see some common findings, such as, or I would say not so rare findings, such as an aortic aneurysm in a patient who does not have risk factors for atherosclerosis, that's when you need to suspect aortitis and you need to start with your diagnostic workup. Thank you very much.
That was so amazing and informative. I hope Teresa got as much out of that as I did, since she's recently diagnosed. And speaking of you, Teresa, I thought this might be a great time for you to just share a little bit with us about your journey and your diagnosis and how you got there.
Sure. So having a aortitis means that I do breathe like Darth Vader's daughter. And so I just want to let you know I don't normally talk like this, breathe like this. It's been a month since my diagnosis, and I got to see my rheumatologist yesterday for the first time, which is a big step for me. My journey started with my cat at the beginning of the year. He was coming to the end of his life, and his little claws got long, and he poked through my pants and poked through my skin, and I ended up with Bartonella Hensley neuroretinitis, which I lost vision in my left eye. It went away and came back. It was extremely rare and hard to diagnose. And I was hospitalized in Seattle in April. And during that hospitalization, the doctors called a BART code, which is like a stroke. They think I thought I was having a stroke. Couldn't feel anything on my left side from head to toe. All the imaging showed nothing's wrong. My neurology was just fine. So they started scratching their heads. And luckily my infectious disease doctor was able to put things together, and he started looking at my heart, and then got me a cardiologist who got me a PET scan, and they found the aortitis. So I really appreciated the I took notes, Dr. Vaglia, the medical to layperson language. I find it extremely hard to understand, comprehend all of the different letters, GPA, IgG4. There is just this incredible sort of jargon speak or medical speak that goes on around this disease. And as a newly diagnosed patient, it is overwhelming to try to wrap your head around it. I also am having trouble just explaining it to my family members, what's going on with me, why I struggle so much just to get up and use the restroom, come back, why I can't talk on the phone, all those things. It is such a large impact on my life. I was very active before, so I would appreciate any sort of thoughts that you would have on how to speak to family members as to what to expect. Some, I think, family members I believe I'm not going to be here very long, so because when you Google aortitis, it's scary.
Well, Teresa, you take a break for a second and let Dr. Vaglio respond to any of that he feels comfortable responding to.
Yeah, I understand that it can be scary when you Google aortitis. I understand that it's tough to explain to your friends or your family members what you have. But so you can say you have a disease that generally involves the immune system, and the immune system reaction is concentrated in your aorta, and the aorta is very important, is the most important artery of our body. That already gives an idea of what kind of disease we're talking about. The second point is to understand the reason for aortitis and the complications that aortitis had in your case. So I don't know from your case whether you have a dilatation of the aorta, whether you have an aneurysm of the thoracic aorta, which is the cause of your shortness of breath. And I don't know what the etiology is, or what the cause of aortitis is. And these would help you explain better your condition. I deliberately mentioned all the acronyms such as GPA, GCA, IgG4 related disease, not because I want to scare you more than you're scared, but because it's I think it's necessary to become familiar with these diseases, because these are the so-called differential diagnosis of aortitis. So when you speak to your rheumatologist, when you speak to your vascular doctor, to your surgeon, you need to understand the core of the disease. You need to understand what is important for you, what is the potential complication of the disease, but you also need to understand, or to say, my disease is within systemic vasculitis, my disease is within a systemic autoimmune disease such as lupus or whatever. So I did it on purpose to tell you some strange words, some strange acronyms, because I think that from time to time, from, you talk to a doctor to you talk to another, and then you become more and more familiar with these diseases and you understand better. But again, I could explain to your family members your case better if I knew what the complications of the disease were in your case.
Dr. Vaglio, so we don't have answers to those questions yet. My ears perked up when you said IgG4, because that was one of the tests that I took yesterday. And there were several that you listed in your acronyms that I'm being tested for. So they just don't know quite yet. And I don't have the answers because I'm still so newly diagnosed, I guess. So thank you for that, because I think with a rare disease like this, there tends to be the go-to. They want to send you to a neurologist because you're showing a presentation that normally a neurologist would deal with. And I think I have frustrated several neurologists because they're like, we don't know what's wrong with you.
I understand.
And it's very hard to hear that what you're going through is stress. And I'm thinking, stress? I don't feel stressed, and so
You feel bad.
yeah. So thank you for that. I appreciate it.
So Dr. Vaglio, we have some questions that have come from other patients, but I thought before I did that, I would just make sure. Teresa, do you have any specific questions you want to ask him?
I do have a question, because when you tell your story, Kathy, you and other vasculitis patients that I meet on the foundation support group calls, they talk about having remission. Is aortitis something that and I realize it's a general term now, and I'd have to figure out which one I have, but is that something that is something that I can look forward to, remission?
Yes, absolutely. Many of the conditions that can be the cause of aortitis are diseases of the immune system that can be treated, and the disease can go into remission.
I see.
Well, that's some great news, isn't it?
Yeah, that's fabulous. I also have a really elementary kind of question. I know that my aorta has enlarged. Will it reduce in size, or once it's enlarged, does it stay that size then? And we just try to manage it at that size?
It is a principle of physics and biology that when a vessel starts to dilate, to enlarge, it doesn't go back, it doesn't return normal. So it can remain large forever, but the tendency is to progress.
Okay.
So the best thing to understand how to manage this process is to define when this dilatation is too much, when the aorta is too aneurysmal, too enlarged, and in that case, a surgeon needs to repair. So in the early phases of the disease, when the aorta has not enlarged too much, you can treat the disease with some medications. But when the disease has caused a large aneurysm of the aorta, in most cases, it's the surgeon that needs to repair it.
I see. Okay, here's my final question for you. There's a lot of feeling of no control when you're diagnosed with this. And I'm wondering, is there anything that I have control over, i.e. my diet, my exercise? Is there anything that I should or should not be doing? Like, should I eat Gouda cheese every day, or should I, eat peanuts more? Is there anything that is going to help me help myself?
I think that you should check your diet to a low-fat diet anyway. Most of the treatments for aortitis are based on corticosteroids. So when you start treatment with prednisone or other corticosteroids, you need to check your diet and have a low salt intake, low calories, so not too much cheese and not too much fried stuff. But that really depends on your treatment. And so the diet needs to be tailored on the different treatment approaches that you follow. In general, there is no diet for aortitis.
Okay, thank you.
But really good questions that they made me think. So that was, I appreciate your questions and your perspective, Teresa. And isn't it nice to have Dr. Vaglio to answer them so at a level we can understand?
Yes.
I have a few other questions for you, Dr. Vaglio. We have some that I feel like you probably did address in your presentation. So if I'm repeating something you addressed, just remind me. The first question was, is it possible to have aortitis and another form of vasculitis, or do patients have aortitis by itself? It sounds like you told us that, but would you remind me?
Yes, the answer is yes. You can have aortitis in a vasculitis of the large vessels, such as Takayasu's arthritis or giant cell arthritis. These are the most common diseases associated with aortitis. But sometimes, although more rarely, you can have aortitis in small vessel vasculitis, such as granulomatosis with polyangiitis, GPA, or Wegener's, or microscopic polyangiitis, or this is much rarer, and also connective tissue diseases such as lupus, rheumatoid arthritis. So there are a number of other conditions, but certainly the answer is yes, you can have aortitis within systemic vasculitis.
Okay. And one other question that came in, I'm not sure you addressed this, so I'll just ask it again, is which is more common form of aortitis, infectious or non-infectious?
I would say non-infectious, because if you group all of them together, all of the conditions that I mentioned, this becomes much more frequent than infectious aortitis. I would say infectious aortitis was probably more frequent in the past, when chronic infectious diseases such as tuberculosis were more common. They were less treated, less recognized. When immune deficiencies such as HIV infection were more widespread, uncontrolled, and all of these conditions predisposed to an infectious aortitis. But nowadays, I would say that the diagnosis of non-infectious aortitis is far more common than infectious aortitis.
You know, that kind of leads right into another question and sort of answers a little bit of it, but I'll ask it anyway, because from one patient, they said, was aortitis categorized as a form of vasculitis relatively recently? Because he said he saw lists of many types of vasculitis from 8 years ago, and aortitis was not on there. So he just wants a doctor's explanation.
Well, it's probably because of what I tried to explain before, when I said that aortitis is very rarely a disease limited to the aorta. It's more common to have aortitis as a complication of another disease. So it sort of does not qualify as a disease, and this is why it's not in the list of vasculitis or whatever. It's I can tell you that I agree with this view. I agree with the view that aortitis is mainly a complication of another disease rather than as a disease itself, unless you have, you know, an infectious aortitis which is limited to the aorta, unless you have, sometimes you have IgG4 related disease which is confined to the aorta. In that case, it's very difficult to say whether it's a limited disease or a systemic one. But generally, the diagnosis of aortitis leads you to another diagnosis, and this is why it's not included in some classifications of vasculitis, some lists.
Well, that makes more sense. And
Yeah.
I think that also sort of answers this question. It says lots of times we don't know what the causes or triggers of certain forms of vasculitis are. Is it true, however, that we usually do know what the cause of aortitis is?
Yeah. I mean, all of these diseases, I would say all of the vasculitides are idiopathic diseases, even if we are now more and more familiar with the genetic predisposition, with environmental agents that can predispose to the disease. Anyway, these conditions remain without a single determinant. So they are caused by I would say, an accumulation of risk factors. So it's very difficult to say whether you have a specific cause for one of these diseases. Most of them remain without a cause. It's easier to say this is a bacterial aortitis when you find that, you know, Mycobacterium tuberculosis is the real cause of aortitis. Mm-hmm. So there is a causal effect between the bacteria and the complication. But in the case of systemic autoimmune diseases, we don't have an answer yet, or probably we have many answers together.
Yeah. So, and also, there's another question that reminds me a little bit about Teresa's story, because it's when treating infectious aortitis, is it more important to first treat the infection or the vasculitis? That's based on the fact that they know that it came from a form of vasculitis, or are they both treated at the same time? Does one carry a bigger risk of treatment?
Well, in the case of Teresa, I understood that she had a Bartonella infection, so she had an infection, but I didn't clearly understand whether aortitis was put in relation with the infection or not, my take is that it's probably something coincidental, or maybe it's still to be investigated. So in the case of infection, you should certainly treat the infection. That's, I mean, no doubt about that. But you need to understand whether the infection is the cause of aortitis. And sometimes if aortitis has led to an enlargement of the aorta, to an aortic aneurysm, even if it is infectious or whatever the cause, you need to inquire a vascular surgeon to understand whether it requires surgical repair or not. So the approach must be combined. It's not just an antibiotic therapy or immune suppressive therapy or surgical therapy. It's generally a combined approach.
That's what I was going towards that, because sometimes, Teresa, you're smiling. Did you want to say something about that?
That came up at my appointment actually yesterday when Dr. Vaglia is saying they want to make sure that the Bartonella is completely resolved, and they won't go ahead with the immunosuppressive plan until they have complete assurance that they're not going to start that, and then my Bartonella comes back raging if it's hiding somewhere. So it's like he said, it's important to do them in succession or in tandem. I just want to say, ask one more question, because it seems like with aortitis, I am now in competition with COVID-19 patients in end stage that are taking drugs that may actually help my disease. And so in this very competitive, almost medical landscape, is there anything that you would recommend for patients like me in order to advocate for ourselves so that we can make sure that we are the ones getting the medications that we need in order to, survive? And I would hate to compete with somebody who's got COVID, but I love my family too, so.
I personally have really no answer to this question. It's I mean, it really depends on some factors which are not part of my expertise, which is something related to financial or big economical issues. I'm sorry, I can't help. I can certainly tell you that this is not just rhinitis. It's not just having cough. Having aortitis is a serious condition. Therefore, it needs to be approached with with using the best possible care. That's something I can underline, if you wish.
And again, it sounds like what Dr. Vaglia is also alluding to is that we have to just talk to our care providers and trust that they'll look after us in the best way, which is often the message on these webinars, is that in this circumstance, there are so many different possible causes for aortitis, and we all just have to have trust and continually talk to our care providers. And along those lines, Dr. Vaglia, can you comment generally about any patients that you've treated for aortitis, that, like, what's been the most challenging part of managing the illness, or has there been good outcomes for any of your patients?
I would say that I'm quite satisfied with the outcome of patients with aortitis and periaortitis. And I think that one of the most important points in the management of these patients is to have really a good collaboration with vascular surgeons or thoracic surgeons, because it needs to be one single team. You can't ping pong the patient from one to another and then You need to see them together and make a decision, which is a decision based on a surgical criteria and medical criteria. And I think once you establish a sort of even very small team of physicians who take care of aortitis, it's kind of a something contagious that you become interested and another one becomes even more interested, and then you read an article and then you treat a single patient. So at the beginning it was a little bit tougher, but once you become familiar, it's easy, and I would say it's good outcome for patients with this kind of diseases.
Well, that sounds very optimistic for you, Teresa.
I might be optimistic, but this is what I think.
Well, that's great. Teresa, do you have any follow-up thoughts or question for Dr. Bagley? I know you're taking notes furiously and going to get back in touch with your doctors.
I was able to have a PET scan, and going forward, how often do you recommend imaging for your patients with aortitis?
Always. Always for diagnosis. And once you make a diagnosis, then the follow-up imaging studies are, the frequency differs depending on the type of disease. So PET scan is quite expensive. CT angiography can be okay. MRI angiography needs to be done by very good specialists. So there are many variables. But generally, this is a disease that needs to be imaged.
Dr. Baglio, when you're treating somebody for aortitis, how often do you see them?
Oh, initially every month, once a month, once every 4 or 6 weeks, and later on every 3 to 6 months. So, but the initial phase is quite close follow-up.
Sounds very similar to my path with MPA.
It is.
Very similar. Well, I think that was amazing. I think I learned everything I need to know about another disease that affects vasculitis if it's not directly. I mean, we just learned so much about the differences there. And I hope that, Teresa, you got your answers too. And I want to thank you, Teresa, so much for sharing your journey with us, because it's a very personal journey, but it's super important to other people to know that other patients are going through this, and to be able to ask those questions that everybody wants to ask with Dr. Baglia right on here. We appreciate you so much, working at night in Italy to talk to us in the United States. We appreciate that so much, and helping us to gain a better understanding of aortitis in general. I also need to thank our sponsors. So I'd like to thank Chemocentrics, Genentech, and Amgen for their support of our Road to Wellness webinar series, and they're helping the Vasculitis Foundation provide these valuable educational webinars, and they support our commitment to patient education. We're working hard this year to do a lot of disease-specific webinars, and I encourage you, especially Teresa, to go to the Vasculitis Foundation website. The more you find out about the causes of your aortitis, as Dr. Baglio was alluding to, the different types of vasculitis that could be connected, that's the best place. I've loved it as a resource. So I hope that you will be able to use that too. But thank you both so much.